I found something in the National Archives last year that made me sit back in my chair and reread the same paragraph 4 times. It was testimony from a hospital administrator in Baltimore given before a Senate subcommittee in March 1966. And in it, he said something so plain and so direct that it should have ended up in every history textbook. He said the new reimbursement system they were about to adopt would remove every incentive hospitals had ever had to control their costs. He said it clearly. He said it on the record. Before 1966, hospitals in this country operated under what was called cost-based reimbursement. But that phrase meant something very different than it would come to mean. When your grandmother went to the hospital in 1958, the hospital charged her a set daily rate. That rate was published. It was the same for every patient in the same type of room. A semi-private room at Massachusetts General in 1960 cost $14 a day. That included the bed, the nursing care, the meals, and most of the basic services. The hospital knew what it cost them to run a bed for a day, and they charged a rate that covered that cost, plus a small margin. If they wanted to raise their rates, they had to justify it to the state insurance commissioner and to the community board. They had to show their books. This was not a system designed by socialists. It was a system designed by hospital administrators in the 1930s who understood that a hospital is not a factory and that the person in the bed is not in a position to negotiate. There was something else. If you needed surgery, you knew the price before you went in. The surgeon's fee was set. The anesthesiologist's fee was set. The operating room fee was set. These were published rates, and they were the same for every patient having the same procedure. A gallbladder removal at a community hospital in Ohio in 1963 cost around $350 total. You could call the hospital ahead of time, and they would tell you the price. They had to. It was regulated. Insurance companies at that time did not pay hospitals directly in most cases. They reimbursed patients, you paid the hospital, submitted the receipt to your insurer, and they sent you a check. This meant the patient saw the price, and the price had to be defensible. It had to be a number you could look at and understand. Medical bankruptcy as a category did not exist in measurable numbers. Hospital debt was not a concept that shaped family financial planning. You could have a baby, break your leg, or have your appendix removed without the fear that it would destroy your life economically. The system was built on the assumption that healthcare was a service that had to remain accessible, that prices had to make sense to ordinary people, and that a hospital had an obligation to the community it served beyond simply maximizing revenue. Then Medicare passed in 1965, and everything I just described ended within 18 months. The law itself did not mandate the change. The law said Medicare would reimburse hospitals for the costs of treating elderly patients. That sounds reasonable. It sounds like the kind of thing a public insurance program should do. But the Centers for Medicare and Medicaid Services, which was then called the Bureau of Health Insurance, had to decide what costs meant. They had to create a reimbursement formula. And the formula they created, which was adopted in July 1966 and went into effect in 1967, did something no state regulator had ever allowed. It reimbursed hospitals for whatever they said their costs were, plus 2%. There was no price ceiling. There was no rate review. There was no requirement that costs be justified or compared to peer institutions. If a hospital said a bed cost $50 a day, Medicare paid $50 plus 2%. If the hospital said it cost $100, Medicare paid $102. The 2% margin was called an incentive for efficiency, but it created the opposite incentive entirely. If you are a hospital administrator and you get paid cost plus 2%, you make more money by spending more money. A hospital that kept costs low made less profit than a hospital that let costs climb. The efficient hospital was punished. The wasteful hospital was rewarded. This was not an accident. The American Hospital Association lobbied for this formula. They wrote position papers explaining that hospitals needed flexibility, that costs varied, that rigid rate structures would stifle innovation. What they meant was that they wanted to be able to raise prices without justification, and Medicare gave them that power. Private insurers, who had always followed the lead of regulators, now followed the lead of Medicare. If Medicare was paying cost plus, Blue Cross would pay cost plus. If Medicare was not asking questions, no one else would either. Within 3 years, hospital costs in the United States increased by 34%. That is not over a decade. That is 34% in 3 years. By 1970, the average cost of a day in the hospital had more than doubled from what it had been in 1965. The charge for a semi-private room at Massachusetts General, which had been $14 in 1960, was $43 by 1971. The gallbladder surgery that cost $350 in Ohio in 1963 cost over $900 by 1972. These were not inflation adjustments. General inflation during that same period was running at about 4% annually. Hospital costs were climbing at 8 to 12% every year, and there was no mechanism to stop it because the reimbursement system rewarded the increase. Here's the part that should make you angry. Hospitals began to separate their charges into itemized line items. Before 1966, you were charged a daily rate. After 1966, you were charged for the bed, and the pillow, and the blanket, and the towel, and the soap, and the cup of water, and the plastic tray the cup sat on. Every single item became a separate charge because Medicare reimbursed by item. The more items a hospital could list, the more they could claim as costs, and the more Medicare would pay. This was not about covering expenses. This was about maximizing reimbursement. A hospital could buy a box of gauze for $3 and charge $15 per gauze pad because the reimbursement structure never asked whether the charge was reasonable. It only asked whether a cost had been incurred. The question of proportionality disappeared. Private insurance companies, watching what Medicare was doing, restructured their own payment systems to match. If hospitals were going to charge by the item, insurers were going to pay by the item. If hospitals were going to raise prices every year, insurers were going to raise premiums every year and pass the cost to employers and patients. The entire billing apparatus of American medicine, the thing that makes hospital bills incomprehensible today, was built in the 5 years after 1966. It was not inevitable. It was a choice made by specific people in response to a reimbursement structure that removed every incentive to restrain costs. The people who made that choice knew what they were doing. The hospital administrator I mentioned at the beginning, the one who testified in 1966, said it out loud. He said they were about to create a system that would make healthcare unaffordable. He said it in March. The system went live in July. By 1975, medical debt had become the fastest growing category of personal bankruptcy in the United States. That is 9 years. It took 9 years to go from a system where medical bankruptcy was nearly non-existent to a system where it was a leading cause of financial collapse. The term medical bankruptcy entered the national vocabulary in the mid-1970s because it had to. There was no phrase for it before because the phenomenon did not exist at scale. People did not lose their homes because they went to the hospital. That was not a feature of American life. Then it was. The speed of the collapse is what should catch your attention. In 1966, the average American family spent 4% of their income on healthcare. By 1980, it was 8%. By 2000, it was 13%. That is not a gradual shift. That is a structural break, and the break happened in the years immediately following the adoption of cost-plus reimbursement. The mechanism is traceable, the consequences are measurable, and the people who designed the system wrote memos to each other acknowledging exactly what they were building. Hospitals will tell you they had no choice, that costs were rising because of new technology, because of new drugs, because of labor shortages and regulation and malpractice insurance. All of those things are real. But none of those things explain why costs rose 3 times faster than inflation for 50 consecutive years. None of those things explain why a CT scan that costs $1,200 in the United States costs $200 in Germany, where the machines are identical and the radiologists are equally trained. Technology does not explain price. Reimbursement structure explains price. When you pay for cost without asking what the cost should be, cost becomes whatever the provider says it is. The records are still there. The testimony from 1966 is in the National Archives. The budget projections from the Bureau of Health Insurance are in the LBJ Presidential Library. The internal memos from the American Hospital Association are in their own archives in Chicago, and some of them have been digitized. You can go read them. You can see the moment when people who ran hospitals realized they had been handed a system that would let them raise prices indefinitely without justification. They describe it as an opportunity. That is the word they used. There's a file cabinet in a storage facility in Maryland that contains the original copies of hospital billing records from a dozen hospitals in the Baltimore, Washington area, spanning from 1963 to 1973. I went through about 200 of them. The records from 1963 and 1964 are single-page invoices. Room charge, surgery charge, pharmacy charge, total. The records from 1970 onward are 5, 7, 12 pages long. Same hospitals, same procedures. But now every item is listed separately, every bandage and syringe, every 15-minute block of nursing time. The shift happened in 1967 and 1968. You can see it in the paper. The incentive structure changed and the billing practices changed in lockstep. And 50 years later, we are still living inside the system that shift created. There is something else in those files. In the earlier records from before the change, you can see handwritten notes from hospital billing departments. They are notes about patients who could not pay, and they document payment plans, charity care adjustments, and bills that were reduced or forgiven. The language in those notes is institutional, but not impersonal. There is an acknowledgement that the hospital has a community obligation. By the early 1970s, those notes disappear. The bills become standardized. The language becomes legal. Payment plans are replaced with collection agency referrals. The shift is not just financial, it is philosophical. The hospital stops seeing itself as a community institution and starts seeing itself as a revenue center. That transformation happened in 5 years. The reimbursement change was the catalyst. Medical bankruptcy is now the leading cause of personal bankruptcy in the United States. Over 60% of bankruptcies involve medical debt as a primary or contributing factor. That is not because Americans are sicker than they were in 1965. It is because the cost of being sick is 40 times higher in real terms, and the reimbursement system that drove that increase has never been reformed. The formula that went into effect in 1967 is still, in modified form, the basis for how Medicare pays hospitals today. It has been tweaked, adjusted, and made more complex, but the core logic remains. Hospitals are reimbursed for the costs they report. There is no external standard. There is no enforced ceiling. The system assumes the costs are legitimate because questioning them at scale would require admitting the system was designed wrong from the beginning. Every time you see a hospital bill with charges that make no sense, with prices that seem mathematically impossible, with fees for things you cannot imagine cost what they say they cost, you are looking at the downstream consequence of a reimbursement structure implemented in 1966 by people who were warned it would do exactly this. They were warned in testimony. They were warned in writing. They adopted it anyway because the hospitals wanted it, and the hospitals had more political leverage than the patients ever would. That administrator in Baltimore was right. They built a system that removed every incentive to control costs. Then they acted surprised when costs became uncontrollable.